Thank you so much for that really generous welcome. I'm really excited to be here to talk to all of you about neonatal lymphatic flow disorders. It really wasn't that long ago that we considered many of these disorders, especially the congenital presentations, to be lethal. And that mindset has really changed over the last, 5, 6 years with advanced imaging techniques that we can apply to infants, as well as some targeted therapy that is just emerging. We're really seeing a change in the prognosis of these patients. So the objectives of today's talk is to review fetal development. We're going to go over some postnatal lymphatic imaging as it pertains to newborns and infants, as well as some interventions that can be offered. We'll go over the difference between congenital lymphatic disorders and those that are acquired later in life. And we'll review medical management, including targeted therapies. So the lymph system develops around the 5th or 6th week of gestation. It arises after the cardiovascular system has begun to develop. And that's really important because many of the lymphatic disorders that we know about actually originate from cardiac disorders. So if you have a patient with congenital heart disease, oftentimes they have lymph abnormalities that go hand in hand. So a lot of work that's been done on lymphatics and understanding the system is actually from cardiologists and interventional cardiologists exploring what they've been seeing in their congenital heart disease patients. So lymphatic endothelial cells originate from the venous endothelial cells, and then later on, they'll form the core lymphatic structures. So by 7 to 8 weeks gestation, the lymphatic endothelial cells remodel into lymphatic capillaries and lymphatic collecting vessels that have valves. The valves are not quite mature yet, but in this fluoroscopic image, the blue arrows are pointing to the appearance of valves within a lymph vessel. And we'll go over this again later on in the talk. The next important thing that happens with lymph development is that two central pathways will start to form along the spine, as you can see on this picture in the bottom. And these two main channels are connected by smaller vessels that create anastomoses. The final anatomy for the lymph system includes usually one thoracic duct, and that is most commonly on the left side following regression of the right-sided duct. There are patients who have normal variations in which they have a remaining right-sided duct only, and then there are patients who have bilateral thoracic ducts. And that's not necessarily related to dysfunction, but we consider that normal variance. So just to get a little deeper into lymph angiogenesis, there are two main cellular pathways that signal the LECs to form the embryonic lymph sacs and lymph vessels. And these pathways continue to be active even after birth. And so I'm going to spend some time later on in the talk when we talk about targeted therapies, but just to introduce them now, it's the mTOR pathway and the RAS pathway. And so alterations in either one during development can be either germline mutations, which occur before fertilization, and it's present in every cell. So these can be detected from your whole exome or whole genomes from the blood. But unfortunately, we're starting to recognize that some of these mutations along this pathway are somatic. And so they're not inherited, and you can't detect them from our traditional blood testing for genetic disorders. We've started to use research labs to collect fluid and tissue from affected patients to try and detect these somatic mutations. So when it's all said and done, this is a schematic of what the lymph system and the flow should look like. So the lymph system is mainly to make sure the fluid is balanced throughout the body. It collects interstitial fluid from organs and the skin and sends it up the thoracic duct into, in this picture, is a left-sided outlet into the venous system. Usually it's in the innominate vein or SVC. Lymph fluid contains a lot of electrolytes, sodium being a main contributor, triglycerides, immunoglobulins, lymphocytes, coag factors, albumin, and other hepatic proteins, so patients with lymph disorders could have abnormalities in any of these domains. So in fetal development, oftentimes hydrops is the initial clue that there's something abnormal within the lymph system. The most commonly used definition of hydrops is abnormal fluid accumulation in two or more body compartments, but I have seen it used just for skin edema or anasarca in the fetus. Um, we're not going to talk about immune hydrops today. That is much less common, and non-immune hydrops is more common, and it has way more causes: cardiac, infectious, metabolic, renal. This is not an exhaustive list, but we'll just focus on lymphatic and genetic causes of hydrops today. So one of the more common prenatal findings within the definition of hydrops is chylothorax. About 90% of pleural effusions in the fetus are actually lymph. They can cause a mediastinal shift and result in pulmonary hypoplasia. And so recognizing lymph dysfunction early can help improve outcome and survival. So oftentimes, fetal MRIs will be used to further characterize the chylothorax and take a look at lymphatic channels. On the MRI, heterogeneous T2 signals with dark branching linings portends to dilated abnormal lymph channels, suggestive of pulmonary lymphangiectasia or lymph dysplasia. This MRI is showing what they call nutmeg lung to look like, and then I included a photo of what a nutmeg looks like in case you didn't know, and they're supposed to look sort of similar. So this study was done in 2020, comparing the fetal MR findings to postnatal MR lymphangiograms. And we'll go into a little more detail about these various types of imaging later on, but just to show you a schematic of the fetal MR with the characteristic nutmeg lung, correlated to the same patient on a postnatal T2 weighted MRI having a pleural effusion. And then on advanced lymph angiogram imaging, you could see that the um, lymph flows out into that right lung. And then also on conventional lymphangiography, you see the same exact pattern of abnormality on that right side. So like I mentioned, fetal intervention can be really successful for decompressing these large pleural effusions, improving lung development and survival. The first step is to obtain fluid from a thoracentesis to diagnose lymphatic origin with a cell count. Infectious studies are also done to make sure there isn't a torch infection causing these phenomenon. Karyotype is checked to make sure it's not a lethal genetic syndrome. And then a thoracoamniotic shunt can be placed to help maintain that the fluid is decompressed. So once the patient is born and we know or we suspect they have a lymph problem, there are various ways that we can diagnose it through lymph imaging. Imaging also gives us a good sense of prognosis because there are some disorders that we can identify, and yet we still don't have interventions or medical management. So that's important diagnostic information to share with families. But if there is a procedure, the imaging really guides what can be offered. So we'll go over a non-contrast MR lymphangiography. We'll go through the gold standard of dynamic contrast enhanced MR lymphangiography with 3 access points in the inguinal lymph nodes, hepatic lymph ducts, and mesenteric lymph ducts. After that, direct lymphangiography is often used sort of to gain a little more information about the thoracic duct and the thoracic duct outlet. And we can also look at the thoracic duct outlet with contrast enhanced ultrasound, and I'll show you what that looks like too. So non-contrast T2 weighted MRI is great for identifying big structures in the lymph system like the thoracic duct. It is non-invasive, so it's easy to obtain. And slow-moving non-bloody fluid like lymph produces a high T2 signal. So sometimes if patients are too unstable to have a more invasive imaging technique, we can at least screen them with T2 weighted MR and assess their central lymphatics. Like I mentioned, DCMRL is really the gold standard because it'll show you exactly where the lymph is flowing in the direction that it's going in. It can give you more information in real time about pressure differences in the system, and it's essential for diagnosing any central conducting abnormalities. So the DCMRL starts with ultrasound guided lymph access in those three sites, inguinal, intrahepatic, and mesenteric. And this is just images of the needle entering the lymph node. This is an inguinal lymph node under ultrasound guidance. Once those needles are placed, they're secured, and then the patient is actually moved into the second part of this suite, which is the MRI. So the first image here shows where the ultrasound guided insertion of the needles are done, and then the patient is turned and moved right into the MRI scanner. So I'm sorry, somebody's unmuted. If you could mute yourselves. Great, thanks. So this is images taken from an adult patient who underwent DCMRL. Once the patient's in the MRI scanner, gadolinium's injected into the lymph system and usually reaches the thoracic duct and the thoracic duct outlet by about 7 minutes. These are examples of a very abnormal lymphangiogram from a neonate. This was done with inguinal lymph node access, and so the contrast starts from the inguinal area, and there's no central lymphatic duct seen at all. You see a lot of dermal backflow. These are the bright white channels that go into the skin, and you really can't tell if there's a thoracic duct or an outlet. And so, as you can imagine, this patient presented very swollen and hydropic. This is the same patient when they went ahead and did intrahepatic lymph duct DCMRL. So the injection started in the liver, and you can see the contrast is brightest over the liver and then extends up. You can start to see a little bit of a right-sided thoracic duct in this video, but again, the pattern of flow is very abnormal, and there's no indication that there's an outlet to the thoracic duct up in the neck. So DCMRL is really important for assessing the actual thoracic duct, which is the main lifeline to the lymph system. It's really good at showing dermal backflow that you wouldn't be able to see on a T2 MR, and it can indicate where the obstruction or dysfunction is in the patient. So for the patient that I just showed you, we couldn't see the thoracic duct at all in the DCMRL. So in cases like that, the interventionalists will often switch into direct lymphangiography, in which they use fluoro to put a needle into the thoracic duct directly and then a guide wire transabdominally so they can access the thoracic duct and instill contrast and get a better view of the thoracic duct and the thoracic duct outlet. A less invasive way to get a look at the thoracic duct outlet is to use ultrasound that's contrast enhanced. So the ultrasound contrast is injected into the inguinal lymph nodes, and then the ultrasound is placed at the left or right neck, whichever side you suspect the thoracic duct outlet to be, and you watch until the contrast appears. And so this is an example of the same patient on the bottom who they couldn't identify the thoracic duct in the middle of the patient, and clearly the neck area is very obstructed with lymph contrast. And so they decided to take ultrasound and see if the contrast would pass. So the first image, A, is showing the arrows are pointing to the innominate vein, and then in B, you can see the Lumison or the ultrasound contrast agent starting to come out from that area. So they knew there was a thoracic duct and that the outlet was patent. So now I'd like to talk about a few congenital lymphatic disorders. So the most common that we'll see is pulmonary lymphatic perfusion syndrome, and that can look like chylothorax in a patient or what we call pulmonary lymphangiectasia, which is defined as dilated lymphatic vessels on the pleural surface. You can see chylous ascites, you can see pericardial effusions, although these are less common, especially in isolation. And then if you have multiple areas of the body that are affected, we call it multi-compartment lymphatic failure. This is where the terminology gets a little bit tricky because you'll see both CCLA and CLFD reported in the literature. Essentially, they're the same phenotype. It's a dysfunction in the central lymphatics that will often cause effusions, ascites, dermal backflow, swelling, the whole picture. And so, for the purposes of this talk, I'm going to stick with CCLA. That term was first coined in 2014, and CLFD was coined in the literature later on in 2017. But I think if you dig through the literature on lymph disorders in neonates, you're going to see a predominance of CCLA. So we'll stick with that for today. So just a schematic of pulmonary lymphatic perfusion syndrome. So the lymph is going up the thoracic duct instead of making it into the venous system. It goes out into the lungs and can cause chylothorax or pulmonary lymphangiectasia. And if you have older patients, especially ones who've undergone cardiac surgery, like for Fontan surgery, they can present with plastic bronchitis. I mention that because when you image them with DCMRL, it looks all the same. And so it really depends on the patient and their age for how it's going to translate into their clinical phenotype. So congenital chylothorax is the most common lymph disorder in newborns. We don't see the traditional milky effusions that often because our babies are typically not fed. So if you have a patient who's been NPO their whole life and you go after a pleural effusion and it's milky white when it comes out and you haven't fed them, it's not lymph. You gotta think something else is going on, maybe like PICC line that extravasated or something like that. So only after full fat feeds will you see high triglycerides and the milky effusion. Most often, you're going to see serous effusions or serous sanguinis with a lymphocyte count greater than 70%. Also, coincidentally, you'll see the serum studies showing low lymphocyte count and low albumin, and that'll point you more in the direction of a lymph disorder. So we talked about what pulmonary lymphangiectasia is already. Years ago, the only way we ever made this diagnosis clinically was from a lung biopsy or unfortunately on autopsy. But we can also diagnose it from DCMRL. But if you don't have the option, sorry, I hear a little echo. Okay, great. So if you're not able to obtain DCMRL, a high resolution chest ultrasound can be done at the bedside, and it really shows dilated lymph channels along the pleural surface, and you can make your diagnosis from that. So when central conducting lymph anomaly presents congenitally, you usually have an absent or very abnormal thoracic duct. It could be tortuous, dilated. There can be an outlet obstruction that's congenital, meaning that the lymph to vein connection never formed. It's atretic. And then you'll also see abnormal lymph flow to more than one body compartment. Using DCMRL, sometimes we can identify genetic disorders just based off of imaging. So patients with trisomy 21 can have dilated lymphatics, notably in the head and neck, that can be characteristic for that disorder. And then the RAS pathway, if you have a pathogenic variant, we typically see abnormal thoracic duct. It will be dilated and tortuous, but there'll also be intercostal perfusion. And that's been very characteristic across patients we've imaged. And then for mTOR pathogenic variants, you'll sometimes see a connection between the liver and the peribronchial lymphatic chain. So there's a couple of ways in which acquired lymph disorders come about. So traumatic injuries, obvious. There's cardiac surgery. We used to do PDA ligations. We would often see chylothorax occur after that, TEF repair. CDH repair, anything that's going in the chest that can injure the thoracic duct can result in a chylothorax or acquired injury. Typically, these are medically managed, meaning low fat diet and time for healing, and it usually resolves on its own without any other intervention. The other causes of acquired lymph disorders have to do with abnormal flow, and these are a little trickier to deal with. And so, cable pulmonary shunts, right heart failure, SVC syndrome, venous thrombosis, or for severe BPD with high PEEP and hyperinflated lungs, these all alter normal lymph flow and result in a lot of dysfunction. So lymph flow is highly dependent on a pressure gradient with the venous system. So the venous side needs to be at a lower pressure than the thoracic duct. Despite that, the lymph vessels, they have smooth muscle and valves, and so they do have a little bit of propelling power behind them, and the valves prevent backflow of lymph. But a lot of the genetic disorders we talk about have abnormal development of the channels, and so you'll hear people say channelopathies. So there is no way for the lymph to flow in the correct direction. And then again, if there's a pressure differential, if you have high central venous pressures, that will really impact your lymph flow forward and into um, the innominate or the SVC. Okay, so I borrowed the slide from a colleague just because it's got really great examples of what hyperinflated lungs look like. So we all know that severe BPD is a heterogeneous disease and it affects the lung parenchyma, pulmonary vasculature, as well as the proximal and distal airways. And most of the time, in order to support patients with this severe phenotype, you need to optimize their vent settings, and they end up on higher PEEP, which will result in static and dynamic hyperinflation. And so static hyperinflation means they have intrinsic PEEP. And so changing the vent settings doesn't necessarily cause their lungs to decompress. And as you can see in this last image, this last chest x-ray, the mediastinum is very narrow with hyperinflated lungs. And as you can imagine, this is putting a lot of pressure on the venous system and not allowing the lymph to flow where it needs to go. And so oftentimes these patients become very swollen. So here's just another way to think about it. You have bad lung disease, you need to go up on your PEEP. That increases your intrathoracic pressure, which increases your CVP. And then you get ascites and anasarca and PLE. And because of all these competing forces, you need to go up on your vent support some more. And then it's just a vicious cycle that becomes really hard to break. So in the cath lab under fluoro, we've been able to look at the effect of PEEP on thoracic duct drainage. This patient was on a pretty high PEEP. I don't recall what it was, but there's no flow of contrast out of the thoracic duct into the veins. And then when the PEEP was dropped this is the same patient, you can start to see a little bit of contrast flowing out and into the vein here. It doesn't look that obvious, but it's pretty remarkable that you went from no flow to a good amount of flow. So like I mentioned, less drainage to the venous system results in dermal backflow, and a lot of our chronic lungers will become massively anasarchic. They'll have chylous ascites and protein losing enteropathy, and so they would be considered to have central conducting lymphatic anomaly. We don't talk about protein losing enteropathy a whole lot in the NICU, but it is a diagnosis that we're starting to make more frequently. It's retrograde flow of lymph into the intestinal lumen. So if there's high pressure at the thoracic duct outlet, sometimes the path of least resistance for the lymph is to go within the intestinal lumen. Some things you might notice on your labs are low serum albumin, but also diagnostic is an elevated stool alpha-1 antitrypsin. And the clinical presentation could be nothing or abdominal distension, diarrhea, feeding intolerance, and often anasarca. Okay, so what do we do when we've diagnosed a lymph disorder in our patients? There's a couple of interventions that we use with great success, and one that is not really the standard of care yet. So we'll go over selective lymph duct embolization with glue or a thiodized oil or Lipidol. We'll go over lymphovenous anastomosis and thoracic duct externalization, which is not curative but can help with symptom management. So to embolize selective channels in the lymph duct, you have to access the thoracic duct transabdominally and advance a wire to wherever the leak is, and that's where the coil or glue will be deployed. And the intention is for the coil or glue to just go into the abnormal lymphatic branches. We never want to embolize or ligate the thoracic duct in an infant. They don't have enough collaterals and their development is not complete for their lymph system in order to make up the lack of a thoracic duct. And so patients without a thoracic duct can become very swollen and have ascites, chylothoraces, and no real way to treat them once you've embolized or ligated them. A little more straightforward of an approach is the Lipidol injection. This is usually the treatment of choice for newborns with PLPS and no other abnormalities. Lipidol is from iodine and poppy seed oil. It was actually used back in the 1940s as just a lymph contrast agent, and then people found incidentally that it would migrate into abnormally conducting channels, and because it's highly viscous, it would cause a mechanical occlusion in those abnormal vessels. And then over time, the vessels would sclerose and collaterals would form. And this is what it would look like on X-ray. So I'm giving a case example of a 38-weeker female who prenatally was diagnosed with a right side chylothorax. She had a thoracentesis that confirmed a lymphocyte predominance. She ended up having two thoracoamniotic shunts. The first one fell out. They put another one in. And then when she was born, she was phenotypically normal. She was asymptomatic, breathing room air. And so she was brought to the NICU and initiated on regular breast milk feeds. Her day of life 0 X-ray is not clear, but there's not much of an effusion there. And then by day of life 4, when she started having more work of breathing, you could see that an effusion has developed on that right side. And so she went to have a DC MRL, which confirmed that her only lymph dysfunction is fluid flowing to that right lung. And you can see it on the video and the static image. And so at the same procedure, Lipidol was injected, and you can see the bubbles of oil sort of going out into the abnormal channels where they will just mechanically block off those channels, and they'll end up going away. And the patients do quite well. So here she is after the Lipidol injection. She still has her chest tube in, but that came out shortly after, and she was able to go home on full feeds. So we'll go over lymphovenous anastomosis. This video, I was having a little trouble playing, but you can see that there's a direct connection between the thoracic duct. Let's see if I'll keep playing. That's highlighted in blue, to the external jugular vein. There's no sound because everyone in the room was super excited. This was the first LVA done on an infant here at CHOP. And it was quite successful. Technically, if it's microsurgery, but it's technically not the most difficult surgery, and patients tolerate really well if it's indicated for them. So for congenital causes, if you have an atretic connection, this works great. We've seen cases of venous thrombosis where they need to be rerouted to a different vein with less pressure, and it's worked really well. And so that's basically the next case, was a 39-weeker who came to us after being on ECMO for a couple of weeks. She developed bilateral chylothoraces and a lot of upper body and scalp edema. On admission, her echo did suggest that her SVC was small and narrowed, likely from a thrombosis. And so balloon angioplasty and SVC stent were tried, but that did not resolve her lymph dysfunction. She remained swollen with chylothoraces. And so she ended up getting a lymphovenous anastomosis to reroute her lymph system to a vein that was unaffected. And so the point in time in which her drainage really started to level off was after the anastomosis. And she was able to get her chest tubes out shortly after, and she did not have recurrence of disease. And finally, I'm going to go over an example of CCLA that we ended up doing a thoracic duct externalization. This was a preemie triplet who at birth was very edematous, uncharacteristic for her gestational age. And that seemed to get better on its own. And then at 2 months of age, she had bilateral chylothoraces, and then they resolved on their own. And then 4 months of age, because of severe BPD, she went and got a tracheostomy and developed the severe anasarca that you see in this photo. So at the time, there were a lot of clues that there was something genetic going on with her, but we didn't have the testing to, dig a little deeper other than her serum genetic tests with exome or genome. But to manage her, she went and had her thoracic duct externalized as a way to move the fluid from the lymph system to a lower pressure system. And so this is her MRL. You can see intercostal perfusion. So I suspect that she may have had a rasopathy that we didn't diagnose. There's a lot of dermal backflow here. This is the fluoroscopy from the direct lymphangiogram, and the thoracic duct is very dilated and tortuous. But they were able to access it with a guide wire and then place a catheter in that drained outside of her body. And so over time, she lost a significant amount of weight as lymph fluid was being drained out of her. And this second image with her being very slim was only 2 weeks after they put in the drain in her thoracic duct. So we talked about interventions, but there's a lot to be said for medical management. There's a lot we are still learning, but we know that furosemide decreases pulmonary lymph flow. I think most patients who have chylothoraces or pulmonary lymphangiectasia can benefit from furosemide. It lowers the pulmonary capillary hydrostatic pressure and reduces interstitial fluid formation, so it therefore decreases lymph fluid burden. Sildenafil is interesting. It's a phosphodiesterase inhibitor that prevents degradation of cyclic GMP, and cyclic GMP is needed to mediate lymphatic endothelial cell proliferation, so the development of new lymph vessels. But it's only one case report in the literature saying that it's successful for congenital lymphangiectasia. There's a little more evidence for propranolol, but I wouldn't quite consider it standard of care yet. Propranolol is a B2 adrenergic receptor that blocks lymphatic vessel. So if you have abnormal vessel development, it can decrease that, but the mechanism of action is not clearly understood yet. And then octreotide is sometimes used in different institutions to manage lymph disorders. It's a somatostatin analog. When it causes splanchnic vasoconstriction, and so that works by decreasing hepatic lymphatic fluid production. And most lymph is produced below the diaphragm from the liver and the intestines. And so theoretically, this should work to reduce lymph fluid burden. But we've never had a randomized control trial on it. There was a 2018 report of it improving chylothorax in 47% of cases reviewed. There was incomplete safety data, and octreotide is really risky in small newborns or preemies because of the risk of neck and pulmonary hypertension. So I think we don't really know if it works and what the safety data is for it. So other things that you can consider to treat your lymph patients is changing the diet. I think this is a staple for everybody. Long chain fatty acids are emulsified by bile acid to form micelles, and then the micelles bind with fat globulins and enter the enterocyte as chylomicrons. And so they get absorbed directly into the lymphatic system in this route. On the other hand, short and medium chain fatty acids are absorbed directly into the portal venous system and they don't contribute to lymph fluid. Here's an example of some formulas that we've used over the years. These are all high in MCT oil, but they have varying amounts of calories from long chain triglycerides. I tend to recommend Monogen because it's got the lowest portion of calories from long chain triglycerides, and it's made up of an equal amount of whey and casein, so it's pretty well tolerated. A lot of times you'll see Enfaport being used because that's the only FDA approved formula for infants less than a year old. You might think, oh, gee, Vivanex, that looks great. It's all MCT oil. There's no calories from long chain triglycerides, but it is elemental. And so it's very hyperosmolar. And so we worry about side effects of that. And then Lipostart and Portagen are other options, but Portagen is only made of casein. And so digestibility is not as good. And Lipostart has a decent amount of calories from long chain triglycerides. This is an older study from 2007 that looked at centrifuge human milk. And after 15 minutes of spinning and the fat layer separated, the remaining liquid had no fat in it. And so this is a great option for patients who can't tolerate formula because if you give them their feeds with skim milk and a little bit of the long chain fat formula to make up their calories, they're seeing an overall lower percentage of long chain fats in their feeds. Okay, so now I'm going to spend the rest of the talk on targeted therapies. We sort of touched a little bit earlier on the two main pathways that regulate lymphangiogenesis. That's the RAS pathway and the mTOR pathway. And so starting with the mTOR pathway, mutations are usually seen in PIK3CA, which will upregulate mTOR. And so the treatment of choice might be sirolimus, which is an mTOR inhibitor. This can be effective for overactive PIK3CA signaling, but it acts directly on mTOR, and germline gain of function mutations in that protein are really rare to cause lymphatic dysfunction. And therapeutic levels are not well established in infants. I'm saying all this because we have a different drug that can directly act on PIK3CA, which I'll tell you about in a minute. The side effects of sirolimus are bone marrow suppression and gastrointestinal mucositis, stomatitis, that sort of thing. And so the drug that acts directly on PIK3CA is alpelisib, and this is relatively newer to be used in newborns and infants. So it can act directly on the mutation that is a somatic gain of function in PIK3CA. And so it causes overactivation of that pathway and excessive mTOR. And so this could be a great choice to use if sirolimus isn't working or you have a really severe case. But it's not FDA approved for less than 2 years of age. There's only been 3 case reports that I can find of it being used successfully. And we know some of the adverse effects, but I don't know that we can fully predict all of them yet. And there is a concern that it could lead to NEC if it's causing mucosal breakdown in the GI tract. So switching over to the RAS pathway, so mutations along this pathway will cause upregulation of the MEK protein. And so trametinib is a MEK inhibitor, and that's recently been used with great success for patients who have a mutation along this pathway. So the germline mutations on the RAS pathway, the more common ones you'll hear about is PTPN11, which causes Noonan syndrome, and EPHB4 mutation, which results in cases of CCLA and high drops. We can have somatic mutations along the RAS pathway and KRAS, and so these are trickier to diagnose. Again, you have to send the fluid or tissues off to the lab to see if they can detect the mutation in those somatic cells. But if you do detect it, then the treatment with MEK inhibitor can be really successful because it restructures abnormal lymph vessels, redirects lymphangiogenesis into a normal pattern, and these MRI images show a very dysfunctional pattern on the left. And then 3 months later, you can see a lot of clearing of the abnormal lymph channels and more of a central pattern going up the patient. Just a couple other things to consider when treating your patients who have lymph disorders. You'll often see hypoalbuminemia. I think repleting them with 25% albumin is the way to correct their serum level. I tend to avoid 5% albumin. It's got a low oncotic pressure, so it may worsen interstitial edema and increase lymph fluid. Many of our patients who have drains in will have immunoglobulin losses and present as immunodeficient. Unfortunately, there's no evidence in the literature to support repletion with IVIG, and giving IVIG with a patient who has losses, you're just gonna pour the IVIG out through your drain and probably will not bump your serum levels enough, or at least not long-standing. And just a reminder not to immunize patients who have immunoglobulin losses because they won't be able to mount titers. And as far as I know, I'm not sure people are following up later in life for our babies to check their immunization status. And then, of course, nutrition follow-up is very important. They need to be monitored for essential fatty acid deficiency and supplemented with walnut and flaxseed oil as needed. And typically 3 to 6 months after resolution of symptoms is when fat can be introduced back into the diet. That's all I have for you, and I think we have plenty of time for questions.
Thank you, Dr. Taha, for the insightful presentation. And we would now like to open the floor for the questions from the participants. So now you can unmute and raise your question, please.
Thank you. This is great. I do know, and again, I don't want to let everyone else know, but you do run a big consulting practice through CHOP, that if you have patients like this, there's a way to kind of reach out to you guys for advice, and you're one of the only in the country. Is that correct?
Yeah, that's correct. We have a lymph program that reviews patient consults on a weekly basis, but I'm always available to, talk to referring providers, because a lot of what we've learned over the years is that some patients just get better with medical management. And so we have a lot to offer remotely, and we're happy to do that. If there's a center that does DCMRLs, we're also happy to review it and suggest other treatment strategies from that standpoint.
So in the case you presented that results spontaneously, could you elaborate on the criteria or indicators you use to decide between the expectant management or early intervention in these patients?
So typically the patients that improve are the ones who have isolated chylothorax. I gave a case example of a patient we treated with Lopidol who did very well, and we showed in our review, we published, a case series of 35 patients, and the ones who got Lopidol had a shorter length of hospitalization, and they had a shorter time to full feeds. But we know that there is a subsegment of these patients with isolated chylothorax that will resolve on their own, typically around 4 to 6 weeks of life. And that's probably the culmination of lymphatic collaterals forming after development. And so oftentimes I'll recommend patients who have just a chylothorax to put them on furosemide, give them low-fat feeds, and wait until they're at least a month old, and then we can reassess.
That's great. Thank you.
Are there any other questions? This is usually a pretty quiet bunch. um, If anybody has any questions, please let us know. Otherwise, I would like to thank you so much for agreeing to do this. I know I've been waiting almost a year. I think we planned this.
Yes.
So thank you so much for joining us today. We look forward to you guys joining us next month for neurology as we get close to the neonatal boards. All right.
Okay.
Thank you.
Thank you.
Thank you.
All right. Bye-bye.
Bye.